My name is Dr. Jwala Prasad, and in this video, I will be discussing the scientific basis of AFA therapy and the rationale behind it. I hope that you have watched the first video on AFA therapy so that you can clearly understand further discussion in this video. At the end of this video, I have provided several references as well as a list of proposed and ongoing trials on individual medications that comprise AFA therapy. This video is for informational purpose only. All opinions expressed, even though scientific, should not be considered as recommendations. Conclusions reached and opinions expressed now may change in the future based upon new scientific studies. The contents in part or in their entirety, if used by the viewer for any other purpose, is at the sole responsibility of that viewer. If the information provided is used for treatment, results are not guaranteed. I'm showing this slide from video number 1 to refresh your memory about phase 1 or early course of COVID-19. This slide is to remind you about phase 2 that starts on the 6th or 7th day as the illness due to COVID-19 progresses. Let's see if we can connect the course of illness due to COVID-19 with some kind of a treatment program. During phase 1, there is entry of the virus into tissue cells, multiplication or replication, and spread. The treatment requires specific antiviral medication or a medication with non-specific or generalized antiviral property if the innate or inherent or built-in immune system cannot stop the spread of virus. Monoclonal antibodies can be used during this phase as per emergency use authorization. During phase 2, there is ongoing viral invasion with spread to the lung tissue and other organs with moderate to severe immune inflammatory reaction. In this stage, antiviral and anti-inflammatory medications are needed to halt the virus, help the immune system, and limit the damage to the lungs and other organs. Anticoagulation or blood thinning is needed to avoid blood clots. As the stage progresses or gets prolonged, complications could occur, and there is secondary bacterial infection and failure of lungs and other organs. Antibiotics and other supportive measures are then needed. I'm showing this slide from video 1 to emphasize the fact that the combination of these three medications, azithromycin, famotidine, and aspirin, creates synergy that works well during the early to mid-course of COVID-19 illness. This is based upon the pathogenesis and progress of the disease. It is doubtful that each of the above medications can individually provide the same amount of benefit and success. This slide shows the details of AFA therapy or protocol. For detailed explanation, please watch video 1. A minute ago, I discussed how to connect the course of illness due to COVID-19 with a treatment program. Azithromycin has antiviral, immune regulation or immunomodulatory, anti-inflammatory, and antibiotic properties. Famotidine is a histamine 2 receptor blocker and anti-inflammatory. Aspirin has antiplatelet or blood thinning effect and is also an anti-inflammatory. The antiviral property of azithromycin has been demonstrated in several research studies. One of the studies done by D.H. Tran and colleagues and published under the title Azithromycin, a 15-membered macrolide antibiotic, inhibits influenza A H1N1 2009 pandemic virus infection by interfering with virus internalization process, and published in the Journal of Antibiotic. That study showed azithromycin blocked internalization or movement of the influenza virus into host cells during the early phase of infection. It targeted newly budded progeny virus from the host cells and inactivated their endocytic activity. A single intranasal azithromycin treatment successfully reduced viral load in the lungs of mice. Azithromycin has both anti-inflammatory and immunomodulatory properties. Immunomodulation is to regulate or adjust the immune system during an immune response. An immune modulator is a chemical or medication that may suppress or enhance an immune reaction. Azithromycin upregulates the production of type 1 and 3 interferons and genes involved in the recognition of viruses. Azithromycin decreases the production of major inflammatory cytokines such as interleukins, IL-1, IL-6, etc. This is particularly helpful during the cytokine storm in COVID-19, as discussed in video 1. Azithromycin is extensively distributed into tissue, especially in the lungs, with concentrations much higher than in plasma. For more details, I would refer you to the article Azithromycin for COVID-19, More Than Just an Antimicrobial, authored by Nathalie Blasiak et al. And published in Clinical Drug Investigation. Azithromycin has been shown to exhibit antiviral and immunomodulatory effects, or at least immunomodulatory effect, on several viruses. These viruses include human rhinovirus, coronaviruses alpha and beta, Zika virus, enteroviruses, Ebola, SARS, and influenza A. For details, you can look up the reference review article authored by Madeline Oliver and Timothy Hinks from Oxford University, UK, under the title Azithromycin in Viral Infections, and published in Review of Medical Virology. Azithromycin is a broad-spectrum antibiotic with bacteriostatic activity against many gram-positive and gram-negative bacteria. Viral pneumonias are often complicated by bacterial infections. The 1918 Spanish flu pandemic saw around 50 million deaths ascribed to bacterial co-infections, and during the 2009 H1N1 influenza pandemic, up to 34% of all deaths were a result of bacterial co-infections. Azithromycin, besides its antiviral and anti-inflammatory effect, provides additional benefit as a prophylactic antibiotic against secondary bacterial infection, at least in some cases. The concern of antibiotic resistance is acknowledged, but we are currently in a dire situation globally due to COVID-19. Famotidine, which is the second medication in AFA therapy, acts by blocking the histamine 2 receptors. By blocking the H2 receptors in the lungs, it probably prevents the histamine release from the mast cells from causing hyperimmune response or the cytokine storm. Therefore, it acts as an anti-inflammatory. It has been shown in a small group of patients in a hospital setting to have prevented the need of a ventilator in 48% and probably prevented poor outcome and death in about 45%. This has been shown in a retrospective observational study authored by Mather, Seep, McKay, and colleagues under the title Impact of Famotidine Use on Clinical Outcomes of Hospitalized Patients with COVID-19 and published in the American Journal of Gastroenterology. By blocking the H2 receptors in the stomach, it blocks the production of hydrochloric acid, thereby preventing gastritis and esophagitis. It therefore prevents bleeding that could occur from aspirin-induced gastritis. Aspirin has both anti-inflammatory and antiplatelet properties. It irreversibly inactivates the cyclooxygenase enzymes called COX-1 and COX-2, thereby suppressing the production of prostaglandins and thromboxanes. By suppressing the prostaglandins, it reduces the inflammation process. In the study titled Effects of Low-Dose Aspirin on Acute Inflammatory Responses in Humans, authored by Morris, Stables, and colleagues, they showed that suppression of prostaglandins helps reduce inflammation even with a low dose of aspirin. This study was published in Journal of Immunology. The suppression of prostaglandins also helps modulation or adjustment of hypothalamic thermostat, which helps in reducing fever. Aspirin irreversibly inactivates COX-1 and COX-2 enzymes, thereby suppressing the production of thromboxanes. Suppression of thromboxane A2 in platelets prevents platelets from aggregation or clumping, thereby preventing clot formation. In a retrospective study authored by Dr. Jonathan Chow and colleagues and published in Anesthesia and Analgesia, it was found that 25% of 412, or approximately 103 inpatients treated for COVID-19 were on 81 milligrams aspirin. Those on aspirin showed 44% reduction in the risk of mechanical ventilation, 43% with reduced risk of ICU admission, and 47% with reduced risk of dying in the hospital. I am showing this slide from VIDEO-1 to emphasize the fact that azithromycin, famotidine, and aspirin work in synergy, that the cumulative effect is an important factor. I want to cite these references since they help me reach conclusions. I'm citing these articles because they help me reach certain conclusions regarding the antiviral, immunomodulatory, and anti-inflammatory properties of azithromycin. These are more articles or references regarding azithromycin, secondary bacterial infections in viral pneumonias, and the beneficial effects of famotidine. These references are for famotidine and also about hypercoagulability or exaggerated blood clotting during COVID-19. In this slide, the top three references are for mechanism of action of aspirin and the beneficial effects of aspirin. Then the slide shows the proposed and ongoing trials for azithromycin, famotidine, and aspirin individually in COVID-19 patients. In UK, as of November 2020, there is a large trial being conducted called the Recovery Trial, in which aspirin is being investigated as a possible treatment for COVID-19. Some of the references I have cited helped me reach certain conclusions in the early 2020 when COVID-19 pandemic started. Those conclusions became the scientific basis of AFA therapy. Subsequent studies and references published in mid to late 2020 and our own experience further confirmed that the AFA protocol was a reasonable approach. In conclusion, I would like to mention some important points. AFA therapy is non-specific and may work with mutations. Vaccines and monoclonal antibodies are specific. They may not work with mutations. AFA therapy uses known medications already in common use. We have no antiviral medication for COVID-19 so far. So why not try AFA therapy? If successful in larger populations, hospitalization and deaths could be prevented or reduced worldwide, thereby stopping the pandemic soon. Lockdowns could be avoided even with mutated strains. Many countries will not get vaccines until 2022 or later. We can do vaccination and AFA therapy at the same time. Between AFA therapy, monoclonal antibodies, and vaccination, maybe we can win the war on COVID-19. As I conclude this video, I would like to mention that the coronavirus image is courtesy of Alyssa Eckert and Dan Higgins from CDC. The slides and video were created by Dr. Jwala Prasad, that's me. Thanks for watching. Stay safe and healthy. Together, let's win the war on coronavirus.